impact on the heart. Even ACS patient, if the patient warrants, you can use DP4 inhibitors. And thiazolidines, be aware, be careful in using heart failure or in volume old status due to CKD and all. Now we are focusing from diabetes guidelines to what the cardiology guidelines is, how we have to treat the patients. ESC is clearly said, any patients cardiovascular disease going for a diabetes spectrum or a diabetes patients coming with cardiovascular disease. The first and foremost is, you please confirm this dual spectrum, any heart patients going for a heart failure patients are at risk of diabetes. In due course of time they get diabetes, or diabetes patients presenting with heart failure or ACVDs, please put the patient on class 1 is not metformin, it's not metformin. So European Society of Cardiology does not recommend metformin as the first line. They recommend GLP-1 receptor or SGL inhibitors as the first line of management. Whether atherosclerotic events is predominant, many of the guidelines promote GLP. In the heart failure and CKD is predominant spectrum, you have to go for SGL inhibitors. And if sugar is not under control, you can switch over. You can add or you can switch over to the molecules in between. So this is EAC guidelines. Patient at risk of CV events, don't give importance for glycemic control. Put the patient on class 1 indication, either GLP-1 or SGL inhibitors. If the patient is not able to have control with these molecules, you can invite metformin, and they also given a green signal of class 2B pioglitazone. They are not given sulfonylureas. They are introducing even pioglitazone as a class 2B, then there are sulfonylureas. So patient class 1 is GLP or SGL inhibitors, patient having high risk EV burden, and without control you can go for metformin. This is vice versa of what ADA ESD consensus told in 2018. And ESC guidelines also support patient with heart failure. The predominant here, no GLP is there. Here the predominant is SGL inhibitors only. So patients with high risk of heart failure, put the patient on GLP. If the sugar is not under control on the top of SGL inhibitors, you can invite GLP receptor or DP4 inhibitors which is scientifically proven, like Sita or linagliptin. Then comes metformin and all. But you should not use Saxa or pioglitazone, becomes red. So ACS, you can use pioglitazone, but heart failure, you should be very, very careful to use pioglitazone molecule. These are the common things what are happening here. It is a combined effect. The patient and patient caregivers and the doctors and the diabetes educators, everything has to join together and discuss the patient. Is not possible in our Indian scenarios. These are things what we are having. And AACC, that is American Association of Clinical Endocrinology, says irrespective of the glycemic control, if the patient having heart risk, either ACVD is predominant, GLP-1 receptor, heart failure, CKD is predominant, you can use either SGL inhibitors or you can. But one thing I wanted to was any stroke patient or TA patient, you can use GLP receptor or they are adding pioglitazone in the top of them. Please understand, even patient at risk of stroke and TAA, pioglitazone, because nowadays pioglitazone prescription is being waning out. But European guidelines says atherosclerotic events, you can use pioglitazone on the drugs, but seek the patient as a whole. Patient in heart failure, ACS with the heart failure, don't use pioglitazone. Patient is obese patient, pedal patient, don't use pioglitazone. So these are the things which we had to have. These are the net effect of anti-hyperglycemic heart failure. Thiazolidines, be careful, don't use thiazolidine in the heart failure patients. And you can use SGL inhibitors, GLP-1 receptor agonist, and they've needed metformins. So what are the clinical defects? I'll take another 2 minutes to finish my talk. So let us focus. So we are convinced that any heart patient, GLP and SGL inhibitors goes over, then all other medications. So any patients comes whether heart failure or patient coming with ACVS, the predominant drug of choice should be GLP, either GLP or DP4 inhibitors. Let us focus, any difference is there. Why many of the guidelines says ACVS, you choose GLP as a first drug, heart failure, you choose SGL. So any guidelines, any supportive rationale is there. So these are the studies conducted. So GLP does not increase the risk of heart failure or hospitalizations, but there is no benefit. There is no any decrease in death rate or CVD mortality, like DAPA heart failure trial or Emperor preserved or received trial. We don't have any such data. So we have, even though step-up heart failure is only for preserved ejection fraction, but there is no mortality benefit. Huge mortality benefit is not there as like what we see Emperor preserved, reserved and DAPA heart failure trials. This is a systemic meta-analysis. I have clearly showed that GLP-1 does not increase the heart failure risk. Please understand that this does not increase the heart failure risk. But the beneficial effect offered by DP4s cannot be even GLP-1 receptor agonists. At the same time, DP4s also did not increase any cardiovascular outcomes patients. Though it has clearly showed these trials, these meta-analysis clearly demonstrated these drugs does not produce any harm for the heart in terms of heart failure or in terms of increased CV events. So when you wanted to compare, when you wanted to assess what is which is good, why GLP-1 receptors opted as a stroke or MI than DP4 inhibitors. In the atherosclerotic event, why you are giving much more importance by GLP-1 receptor? They have conducted meta-analysis, the observational study, unweighted studies and weighted studies. They pooled all the data from the studies. they clearly showed 1 weekly GLP-1 receptor agonists scores far better than DP4 inhibitors in terms of reduction of lower ACV events. So the people on GLP-1 receptor had lower ACVD events than that of a SGL inhibitors or DP4 inhibitors for that matter. So it scores more, much more better than that of. This is a systemic analysis. You can see the graph. There is a wide split in the mortality in terms of ischemic stroke, myocardial infarctions, everything. There is GLP scores much more better than that of these molecules, other molecules in terms of reduction. Next is SGL inhibitors. Why they are given more for heart failure spectrum or CKD spectrum? Why they are not having in the first place as like GLP-1 means. This is also systemic review and meta-analysis of 9 studies clearly showed GLP-1 receptors does not have much more wide statistical significance. If you ELIXA, LEADER trial, SUSTAIN trial, the heart failure benefit is not there in this GLP-1 one receptor molecules. But if you take EMPEROR trial or EMPEROR outcome, CANVAS trial, everything shows heart failure patients are more benefited by SGL inhibitors than GLP-1 receptors. So adding together heart failure spectrum, CKD, SGL inhibitors scores much more better than the GLP-1 receptor. Patients having stroke or patients having more atherosclerotic events, GLP-1 receptor scores much more better than that of this. So whenever you write out prescriptions for a patient with heart disease, check whether the patient having atherosclerotic event or heart failure, and top of that check the kidney levels also. So based upon this, based upon the scientific rationale we have, you can incorporate the medication, you can slightly switch over when there is a need. Thank you for the patient listening.
Thank you, sir. Thank you for the informative session. Up next, we have with us Dr. M. Swamikan, who will share with us the intricate management of diabetes in persons with kidney disease.
Dr. M. Swamikan, sir. He is a director of Internal Mid MGM Healthcare, Chennai. He is a member of Indian Medical Association, also a member of Society of Emergency Medicine in India. He won the Young Talented Physician Award in 2001. Also, he invited as a chief guest as a speaker at Scientific Assembly by the American College of Emergency Physicians, Washington, D.C. at 2005. Sir, we welcome you.
I think from morning we have been listening to diabetes, SGLT inhibitors. I don't know how many times it came to, it's ringing into the ears, SGLT inhibitor, all the time. I'm sure it's going to ring throughout the night tonight. So my job is changing this one. Okay, in the bakama. Okay, so I'll be talking on pharmacotherapy of diabetes in kidney disease. You just heard in cardiovascular disease. I think before going into the topic itself, and I'll briefly get into what is mean by chronic kidney disease. Okay, this side I think. Okay, the chronic kidney disease is defined as the presence of kidney damage or decreased kidney function, which means reduced EGFR and increased urinary albumin more than 3 months or 3 months. It's most commonly seen in both type 1 and type 2 diabetes mellitus. The risk factors for developing a chronic kidney disease, you have multiple factors starting from obesity, dietary protein intake, smoking, oligonephropathy, genetic factors, hyperlipidemia, poor glycemic control, proteinuria, glomerular hypertension and systemic hypertension. Apart from this, RA is renal artery stenosis. So you have so many risk factors which can cause chronic kidney disease. So what is the current status? DM is the leading cause of chronic kidney disease worldwide, and you have 20 to 30% of type 2 diabetes patients having renal impairment, which is moderate to severe chronic kidney disease, wherein you have EGFR less than 60. See, the CKD is also serine type associated with severe morbidity and mortality due to increased cardiovascular damages. It is a real challenge in patients with chronic kidney disease to getting the glycemic control because the drugs act differently, not like others. So but the pathogenesis, I will not go into detail. This slide will tell you it is influenced by metabolic factors and hemodynamic factors, which involves a very complex cascade, activation of cellular signaling pathways, oxidative stress, dysregulated autophagy, and epigenetic change. Finally, it will lead into inflammation and fibrosis. Fibrosis will in turn cause diabetic kidney disease. So the major thing is you have to prevent proteinuria at any point. Preventing proteinuria is one of the thing that you have to do is to get the glycemic control. Just quickly, I will tell you the KDIGO's prognosis of CKD based on GFR and albuminuria. One side you have G1 to G2, G3, G3A and B, and 4 and 5. It basically based on the eGFR. If it is more than 90, you have a normal glomerular filtration rate, whereas grade 2 is between 60 and 89. Grade 3A is 45 to 59, and grade 3B is 30 and 44. You have to remember the up to 3B, because after that, the kidney function is drastically comes down. It leads to end-stage kidney failure. So whenever you want to use the drug, you have to see whether they are in which class of renal failure. On the other side, you have proteinuria. It is classified as A1, A2, A3. A3 is less than 30 and A3 is more than 300. In between, you have moderately increased proteinuria, which is between 30 and 300. All your drug management will based on this classification you have to do. Whenever you see a patient with diabetes and chronic kidney disease, you have to put them where they belong because it is going to be very important for administering your drugs. So management of hypoglycemia, good glycemic control is very, very important in patients with CKD because it can prevent lot of cardiac and morbidity and mortality. So it is essential to have your glycemic control within the accepted optimal range. The optimal range is it differs from guidelines to guidelines. If you take the endocrine society, it says the optimal level is 6.5, whereas the ADA and European guidelines says it is less than 7 is ideal. But in chronic kidney disease, you cannot stick to this HbA1c optimal level. You have to modify according to patients' comorbidities. So you have to fix in like in elderly patients. The first speaker said, you have to keep your HbA1c at a higher level for elderly people. So kidney and heart risk factor management in diabetic patients with CKD. It has a pyramidal approach wherein the bottom of the pyramid mainly says lifestyle and self-management, which includes your diet, exercise, and smoking cessation and weight reduction. The first line of drug therapy will be your metformin. Like all the other guidelines says, metformin is your first drug, and the other drugs that should include in chronic kidney disease will be SGLT2 inhibitor and RAS blockade and statin. So you will be comprehensively using the first line drugs. When the first line drugs is not enough, you go to the second additional drugs. That will be GLP-1 RA and antiplatelet drugs and the MRA, newly non-steroidal MRA drugs, which I will be talking to you in little detail little later. So then you have additional risk factors control. That will be your glycemic control and blood pressure control. and the lipid management. And even in choosing lipids, you have to choose the best statins that will work for the chronic kidney disease. So the critical approach to management of diabetic kidney disease, you have the one side you have in chronic kidney disease, other side you have a normal patients. So which includes again for the healthy diet, physical activity, cessation of smoking, and weight management. This first line drug in kidney disease patients, you have SGLT2 inhibitors, and even it can be continued until they reach a stage of dialysis. You need not stop metformin. I'll be talking to you about metformin a little later in detail. So the approach will be same, slightly different from the normal patients compared to the kidney disease patients. So first we will see the trials and tribulations about metformin. Metformin is the only drug which is crossed. It is available in the market for more than 101 years now. So that means 101 not out is a sign of good batting. So it has been there in use since 100 years. Means my professor used to say, if any drug stays in the market for more than 10 years, then that drug is a worthy one to try. So if this has stood for 101 years, you all know how much it is be useful. So let us see this scenario. A patient was admitted in the ICU with urosepsis, lactic acidosis, and renal failure with a known history of type 2 DM and CKD. He was on metformin 500 milligram thrice daily, and also he gets other nephroprotective drugs. The ICU doctor he says like this: this would have never happened in the general practitioner hadn't given the patient to metformin. And is this reaction justified? You will all realize it is not justified. Because traditionally we have been told not to use metformin in CKD, but the current recent guidelines, especially if you go through the UKPDS trial which has been recently published in 2024, it says it can be used if the patient has more than EGFR more than 30 ml per minute. So that reaction was not correct. So using metformin even in patients with acidosis, it can be used. Only thing, if the patient has lactic acidosis, you cannot use. So what is the rate of the lactic acidosis? It occurs in 6 people in 100,000 patient year incidence. That means it's very, very rare. I'm yet to see a patient who is admitted with lactic acidosis because of metformin. Because it's always common to have a lactic acidosis and septicemia rather than metformin induced. So metformin can be used even in the acute setting. That's what they say. If you suspect lactic acidosis, you cannot use metformin. That is the only thing that says the metformin can be used safely if the EGFR is more than 30. It is suggested metformin therapy is more, even in the more advanced stages of CKD, may actually offer therapeutic benefits and then outweigh any possible risk. That means lactic acidosis. So if the metformin can be used if the EGFR is more than 30, it is usually excreted in the urine unchanged, and the metformin dosage can be reduced as per the EGFR. The lower part of the slide shows how much you have to reduce in patients with CKD. And stage 3B, this is what I was telling, 30 to 44, you can reduce the dose to 1000 milligram. Actual dosage will be 2000 in any given patients without renal failure, but when the renal failure sets in, you have to reduce the metformin dosage. As you go to stage 4 and stage 5, you cannot use metformin, you have to stop. So contraindications, as I already alluded to, we'll go to the sticky situations about the sulfonylureas. A 72-year-old man discharged from the hospital. Morning after he presents to the ER in the morning having collapsed with the blood glucose of 39.63. He has had type 2 diabetes for 6 years, for which he takes metformin, sitagliptin and glycoside. A recent HbA1c was measured at 6.3%. He admits experiences up to 2 hypoglycemic episodes per week. He does not check his blood sugars at home. Examination reveals a blood pressure of 132/82, heart rate of 78, and it was regular. His BMI is 28. Serum creatinine was found to 1.4. Which of the following response is most appropriate for this patient? Stop the glycoside, keep this medication unchanged, stop sitagliptin, start insulin, start metformin. Which one will be a response? Anybody? Okay, stop glycoside. I wouldn't totally agree stop glycoside, because glycoside is an insulin secretococcus. They lower the HbA1c 1 to 2%, and it can cause hyperglycemia. As the GFR declines, you saw the template patient's creatinine was 1.4. The eGFR tends to go down when the chronic renal failure sets in. So I have only 1 minute. So it tends to clear very slowly, so the hypoglycemic rates will be, you can reduce or stop. Both the options will be right. So sulfonylureas, these are the sulfonylureas currently available. You can, the most commonly used ones are glimepiride and glycoside. Glycoside can be used when the eGFR is more than 60, and the glimepiride also can be used, but you have to use with caution. The talk of the town, I think from not only talk of the town, talk of the conference is SGLT inhibitors. Today you have been seeing everybody is saying SGLT inhibitors. So it can be used even in patients with CKD, even when the eGFR is more than 30 or more than 20. So it's one of the drugs that reduces the cardiovascular morbidity and mortality. So dosage selection, if you have patients with eGFR more than 20, high priority should be given for SGLT inhibitor, because it has a very good cardiovascular outcome, reduction in morbidity and mortality. Also it reduces the regression in eGFR worsening. So there are enough talk went on from this morning. The most popular one is EMPOWER trial, which showed there is a definite cardiovascular benefit compared to the placebos. So EMPOWER trial, CVD Real 3 trial, DAPA CKD trial, all the trials said it can be used in CKD because it offers a good cardiovascular benefit. Then DPP4 inhibitors can be used in CKD, but the three drugs that we commonly use is sitagliptin, vildagliptin and linagliptin. Linagliptin doesn't need any dosage adjustment, whereas the vildagliptin and sitagliptin will need a dose reduction when the eGFR is less than 30 to 45. You have to use 50 milligram sitagliptin, and if it is between 15 and 30, you can use 25 milligram of sitagliptin. Vildagliptin you can reduce to 50 milligram to 100 milligram to 50 milligram, whereas linagliptin doesn't need any dosage adjustment. So the other drug that is being recommended is the GLP-1RA that can be used in chronic kidney disease. As you all know, semaglutide is one drug that can be used in CKD, and it offers a good weight reduction. The injection has not come to India. It was introduced in 2018 when I was there in the US. That's the time it was introduced. It is still to come to India because of the big demand all over globally. Because of the just demand is more outside the India, it has not come to India. Not that because of the cost, it's not been brought to India. So at some point of time, it will be available here in India. I think in 2026, it's going to come to India as injection. So as far as insulin is concerned, insulin again, it's mostly cleared by the 30 to 70% of the insulin is cleared by the kidneys. So it is dosage adjustment is required. All the insulin can be used, but the rapid acting insulin is the preferred one. So I'll skip some of the slides because lack of time. The new kid in the block is finerenone. Finerenone is good outcomes in patients with diabetic kidney disease for two reasons. One, it prevents the progression of the kidney disease, and it also reduces the proteinuria. So it can be used when the EGFR is more than 30. Safely it can be used. So the only thing is using finerenone, you have to be very careful about the hyperkalemia, because it can cause hyperkalemia. If you encounter hyperkalemia, you have to stop it for shortly, then reintroduce and see whether they tolerate. If they tolerate well, you go up to 20 milligram and continue. It can prevent the end-stage renal disease. It can also prevent proteinuria. That way you can have a good outcome in. So you have, there are several mechanisms which contributes for renal damage. One of the mechanism is inflammation in the kidney that leads to fibrosis. Inflammation leads to fibrosis. This mRNA is supposed to reduce the inflammation and prevent the renal failure. So finerenone is available in 10 and 20 milligram. So there are two trials which concluded, the Fidelio trial and Figaro trial. The principal investigators, once he came to Chennai, he presented, I borrowed these two slides from him. Both the trials showed reduction in cardiovascular morbidity in stage 3 to stage 4 and as well as in stage 1 to stage 2. So both the trials to put together, now another trial has come, what is called Fidelity trial, and all the trials indicate that it can prevent the chronic kidney disease leading to end-stage renal disease. So we have to be, as I said, you have to be careful about the hyperkalemia. If the potassium is less than 5.5, you can safely use the finerenone. So he was here in Chennai, the principal engineer Louis Roop, and I happened to meet him. So to conclude my talk, metformin still can be used in chronic kidney disease. You need not worry about lactic acidosis, and finerenone is a new drug that can be used in diabetic kidney disease, which can prevent the chronic kidney disease. So my talk will not be complete without mentioning these two persons' name. One is Arjun, he is here, and Sri Lakshmi. Both of them helped me in producing this presentation. Thank you. We'll take the questions at the end of this session. Thank you.
Thank you so much, sir. Thank you very much. To conclude this pharmacotherapy session, we have with us Dr. M. Ravikiran, who will enlighten us about the hepatic considerations that are to be taken in the management of diabetes.
Dr. M. Ravikiran, sir. He is a consultant endocrinologist at Dclub Endocrine Center at SRM SIMS Hospital, Vadaparni, Chennai. His book chapter authorized Manual of Endocrinology and Diabetes, published by Endocrine Society of India. Sir, we welcoming you.
Thank you for inviting me to this August gathering. So this will be a short run on managing diabetes mellitus in liver disease. There are a lot of associations between diabetes and chronic liver disease. There are a lot of independent and direct associations. Hemochromatosis, HCV, cryptogenic cirrhosis, alcohol, NAFLD, they all linked to both cirrhosis as well as diabetes mellitus. Diabetes itself is a risk factor for HCC and increased mortality. Cirrhosis in diabetes patient leads to increased mortality. Diabetes in cirrhosis patient leads to increased mortality. There is also an independent association running through the common origins in terms of obesity, lipid dysmetabolism. Both can lead to NAFLD, both can lead to diabetes, eventually to cirrhosis, and rarely HCC. The intricacies we have to consider in detail. Patients with liver cirrhosis, at some point of time they develop portosystemic and intrahepatic shunt. So from the insulin in the portal vein has a chance to go directly into the systemic circulation without being processed by the liver. So there will be peripheral hyperinsulinemia, excess insulin in the peripheral circulation. This excess insulin downregulates number of insulin receptors in muscle tissues and may result in insulin resistance. And few other factors are there. Chronic hepatitis C virus may impair insulin receptor substrate 1 signaling and lead to insulin resistance. So the association between presence of diabetes and worsening of CLD complication is well documented. In many studies they have shown DM in decompensated CLD patients associated with hepatic encephalopathy, portal hypertension and bleeding from esophageal varices. And diabetes in chronic hepatitis C is an independent predictor of ascites, spontaneous bacterial peritonitis, renal dysfunction and eventually hepatocellular cancer. A lot of studies are associated, they have been listed in this. What are the predictors of mortality in chronic liver disease? The very presence of diabetes or even impaired glucose tolerance can be a risk factor. Higher child pug score and raised serum creatinine. So whenever we treat a person with liver disease, essential to look at signs and symptoms of decompensation like bleed, ascites, worsening INR, and also calculate the child pug score. Now moving on to individual diabetes drugs in CLD, metformin is eliminated unchanged by kidneys. There are a lot of benefits for metformin. It improves metabolic derangements in obesity related liver disease, reduces insulin resistance in hepatitis C related CLD, has been shown to decrease mortality in cirrhosis patients and decreases progression to hepatocellular carcinoma. So at least in long term there is a definite advantage for using metformin in CLD. And few studies have documented over quite a long term also. Over 5 years, researcher has documented that significant reduction in hepatocellular carcinoma prevalence and incidence was found. And the reduction in mortality was found not only in the early stages of CLD but also in stage B and C child pug. And already alluded to by Dr. Swamikannu sir, lactic acidosis was not found to be especially worsened by metformin use in a careful manner. Already published data are there. And pioglitazone, we all know it improves insulin resistance, it is beneficial in NAFLD, but whether it improves virologic response itself when given with other antiviral agents, few studies explored that. One study told that when given as a triple combination with ribavirin and peginterferon, there was a benefit even for virologic response. After 2 years, one other study came that didn't show any virologic benefit. So that's a question still to be answered. Sulfonylureas, the modern sulfonylureas we use will be glibenclamide, glycoside, glipizide and glimepiride. These ones will be the common in vogue. Glibenclamide and glycoside metabolized in liver and eliminated through bile and kidney. In advanced liver failure, better to avoid these two agents. Glipizide has a short half-life, So the probability of hypoglycemia through use of glipizide is somewhat less, even in advanced liver failure. Glimepiride metabolism is not altered in a big way, even in child B or C. We can continue to use them in mild or moderate liver impairment with caution, however not recommended in severe hepatic impairment. Glynides are by nature short acting, however in liver dysfunction the pharmacokinetics may differ. Natiglinide pharmacodynamics is not altered, might be safer, however ripaglinide, which is supposed to be rapidly eliminated through bile, it may accumulate in advanced liver insufficiency, so relatively contraindicated, ripaglinide. DP4 inhibitors, it's weight neutral, quite safe in mild liver disease, mild decompensated and uncompensated uncompensated and mild uncompensated liver disease. However, few researchers have raised few queries about use of DP4 inhibitors. This slide is about one such data. Around 2,800 diabetic patients with compensated liver cirrhosis. It was a retrospective trial data. They found that decompensation was higher with continued use of DP4 inhibitor. The adjusted hazard ratio was 1.35 for decompensation in those patients who were originally compensated. Variceal bleeding risk was higher by 1/3. Hepatic failure risk was higher by 1/3. However, risk of all-cause mortality, hepatocellular carcinoma, and major cardiovascular events were not statistically different. So there are few pathophysiologic basics also which may create some anxiety. DP4 inhibitors increase GLP-1 and GIP levels in splanchnic and portal circulation, putatively can promote nitric oxide production, accelerate portal vein inflow and increase portal pressure. These are all theoretical. The final word is not yet out. We can comfortably use them in compensated liver failure, and in mild uncompensated liver failure also we can continue to use. In moderate liver impairment we have to use with caution. Better to avoid vildagliptin in all forms of uncompensated liver failure, because the label doesn't permit usage in uncompensated liver failure, even though we all may be having anecdotal evidence of use in our own patients. Label does not permit use. SGLT2 inhibitors, higher systemic dose exposure in advanced liver disease. It is useful in NAFLD related liver disease, and it can very well address comorbidities like obesity and DM in the commonly found NAFLD. GLP-1 receptor agonist, liraglutide and semaglutide has been shown to have beneficial effect in obesity and CLD. In this 72-week randomized control trial, around 300 patients with confirmed NASH and liver fibrosis were included. Once weekly subcutaneous semaglutide was used compared with placebo. Semaglutide showed higher NASH resolution than placebo. Fibrosis stage did not significantly improve. The potential mechanism could be weight loss, reduced insulin resistance, and improvement of metabolic dysfunction. The nature of insulin requirement may differ in compensated cirrhosis versus uncompensated cirrhosis. Compensated cirrhosis may be having insulin resistance, the insulin requirement could be high. However, once patient develops decompensation, the insulin requirement becomes low. Long-acting insulin can be continued to use with caution. We have to check more frequently for hypoglycemia. However, short-acting analogs can be used safely, Lispro, Aspart and Glulisine. The pharmacokinetics is not significantly altered. Glargine, despite very long usage history, doesn't have any significant published data in CLD. However, with our experience, we can continue to use with care. Dclub, there is a published data, it is safe in CLD. So diet for diabetes and CLD, for those with decompensated liver cirrhosis, we have to think about starvation and sarcopenia, especially in decompensated cirrhosis. We have to screen for sarcopenia. Clinically, we can do so by grip test or mid-arm muscle circumference or in research settings, we can do computed tomography assessing psoas muscle area at L3 level. So for those with decompensated liver cirrhosis, adequate nutrition or high protein diet 1.2 to 1.5 gram per kilogram is needed to avoid loss of muscle mass and to reduce the occurrence of ascites or edema. However, for those who have mild liver disease or those with NAFLD, prominent signs of insulin resistance, low calorie, low fat diet with increased physical activity has been shown to improve both morbidity and mortality. So a few words about NAFLD. We all know that there's a common shared platform with the diabetes, a healthy liver, insulin resistance, weight gain, high cholesterol, fatty liver ensues. At this stage it is reversible. Few other risk factors added up, then it progresses to non-alcoholic steatohepatitis. A dysmetabolism in adipose tissue, it spills over into inflammation, microinflammation within the liver cells also. A lot of risk factors at this stage. A multi-hit theory goes around. Oxidative stress, mitochondrial dysfunction, inflammation, apoptosis, gut-derived endotoxins, immune cell activation. Even at the stage of NASH, it is still reversible. Once it goes to advanced fibrosis or cirrhosis, it is not reversible with medical therapy. So the few popular drugs for NASH today, pioglitazone, it decreases insulin resistance and decreases free fatty acid flux. SGLT2 inhibitor, it decreases body weight and has been shown to improve adiponectin level. GLP-1 receptor agonist, liraglutide and semaglutide, decreases free fatty acid flux, decreases body weight and indirectly decreases inflammation. And there is tirzepatide, it is a multi-agonist agent. Again, similar benefits are seen with tirzepatide also. So the popular drug treatments, they benefit NASH significantly. However, no drug in this list is FDA approved as such. Obeticholic acid, vitamin E typically not useful in diabetic. We can use it for non-diabetic fatty liver. Pioglitazone, saroglitazar, and liraglutide or semaglutide, all this is popularly used. So they have differing benefits in NAFLD. The metformin enthusiasm has kind of waned for NAFLD because we know that it may not alter liver histology. However, metformin has other long-term benefits in terms of decreasing progression to HCC and improving the mortality in CLD. The body weight is definitely decreased. Body fat is also decreased with metformin. However, the biochemical changes are inconsistent and no definite liver histology improvement with metformin. Thiazolidinedione, much better in that aspect. It improves both liver enzymes as well as liver histology. GLP-1 receptor agonist, similar to pioglitazone, its effect on liver enzymes and liver histology. DP4 inhibitors is fairly neutral when used in a safe scenario. SGLT2 inhibitor, in view of its other weight loss and other benefits, liver histological changes have not been convincingly demonstrated so far. However, body weight decreases, body fat decreases, and liver enzyme may show improvement. So the more the weight loss, better the resolution of NASH. Weight loss of 5 to 7% decreases steatosis. 8 to 10% weight loss has been shown to reverse steatohepatitis. Greater than 10% weight reduction may actually even reverse fibrosis partly. So possibly only bariatric surgery will be able to give more than 20% decrease in weight. If that is achieved, it results in resolution of NASH in 70 to 90%, improves fibrosis in 50 to 65%. So far, resmetirom is the only drug cleared by FDA. It's actually an anti-fibrosis agent. It's a liver-directed thyroid hormone receptor beta subunit agonist, the only FDA-approved drug for NASH so far. So summary of anti-diabetic medications. In the last column, we can see when there is severely impaired liver function, probably the only drug we will be left with is insulin. Short-acting insulin along with a careful dose of long-acting insulin should do the trick. In the other stages of CLD, we have to carefully check at child pug score and other side effects, and institute medicine. Thank you all for patient listening.
Thank you so much, sir. I think it was a very delightful session and we all learned much. Thank you to all the speakers. Due to time constraints, we will be moving on to the next session. Today we have with us Dr. Deep Chand Raja, who will be sharing with us on the clinical approach to arrhythmias in diabetes. Over to you, sir.
Dr. S. Deep Chandrajan, sir. He is a senior consultant of cardiologist. He is a clinical lead cardiac electrophysiologist at Kaveri Hospital, Chennai. Also advanced clinical cardiac EP fellowship. He performed 1500 plus cardiac EP application and device placement. Also he gave 50 plus applications in international and national journals. We welcome you, sir.
Good afternoon, one and all. It gives me immense pleasure to be here amongst my seniors and colleagues, respected seniors, and all my colleagues, Dhanamidharan sir, Parandaman sir, Natarajan sir, Swami Kanna sir. It's again, thank you for this wonderful opportunity. So my topic is clinical approach to arrhythmias in diabetes mellitus. Any cardiac arrhythmia, the basic concept is that is either a block in the conduction, which means there's a conduction disturbance, or there is an abnormal impulse formation. So this mix of abnormal impulse formation and abnormal conduction is what is leading to an arrhythmia. It could be bradyarrhythmia or tachyarrhythmia. So what happens in diabetes mellitus is autonomic dysfunction, that is the underlying problem, and then cardiomyopathy. Both of them play together. It is an intertwined mechanism. Both of them play between each other, resulting in that substrate for arrhythmias. This is a DCON conference, but in diabetes it is a DCAN that causes a problem. Diabetic cardiac autonomic neuropathy. The balance between, all of us have learnt about homeostasis. So whenever this homeostasis gets disturbed, the equilibrium gets disturbed, excess sympathetic or less of parasympathetic because of diabetic, it not only causes peripheral neuropathy, it also affects nerves supplying to the heart also. It increases the resting heart rate, decreases heart rate variability, sets up the substrate for arrhythmias. This is something which I would like to highlight here, hypoglycemia-induced arrhythmias, which is an under-recognized phenomenon, and all of us treating physicians should keep in mind that hypoglycemia undetected can cause sympathetic overactivity, can be a predisposing factor for both tachyarrhythmias as well as conduction blocks. Let's go through some certain examples. So, a 54-year-old female, diabetes mellitus, 6 years, history of blackouts. Whenever we have this history of blackouts, we know that we are dealing with something called a cardiogenic. If you have excluded the neurogenic causes, what is left is cardiogenic. So, in this case, as you see, the P waves, so much of P waves there, and then intermittently it is conducting into the QRS. If you see V1, a left bundle branch block morphology, and suddenly that becomes a right bundle branch block morphology. So this is called a high-grade AV block where more than 2 P waves get blocked, sometimes conducting with LBB morphology, sometimes conducting with RBB morphology. If such a patient comes with history of blackouts, it is likely high-grade AV block, the patient would need a pacemaker. So this patient landed up with a pacemaker, but the QRS looks very narrow for a pacemaker, correct? This is because we are used to seeing this type of QRS, which is 180 milliseconds wide QRS if a pacemaker is put in. But over time, nowadays, we come up with pacemakers where we can offer QRS as narrow as 110 milliseconds. Especially useful in the context of diabetes mellitus because broad QRS has been shown to lead to an increased incidence of pacing-induced cardiomyopathy, which is pacing-induced heart failure. So, we always target a QRS, very narrow QRS. This all started in 2017, where the Chinese cardiologist Dr. Huang demonstrated that it is possible to penetrate the interventricular septum and place a lead and capture the left-sided conduction system, which we call the left bundle pacing. So that particular case which I showed you was in the, if you see the X-ray in the left anterior oblique view, across the interventricular septum, you are pushing the lead across to capture the left-sided of the septum, left-sided portion of the septum, which we call the left bundle pacing. So this is a case example which I showed was an AV block. Similarly, 6 sinus and all the bradyarrhythmias have a high incidence in diabetes mellitus. This was a longitudinal cohort study, 6 lakh patients with diabetes, versus 23 lakh people without diabetes. What they showed, with every age, as the age increases, the incidence, what you see on the red side, the red color, is the higher incidence of bradyarrhythmias and higher incidence of sinus node disease, AV block and pacemaker. Everything is higher when compared to a non-diabetic in the same age group. So a 48-year-old male with diabetes mellitus for 15 years, history of giddiness. But the ECG is showing something different. The ECG is showing, in fact, what is the ECG showing? The ECG is showing atrial fibrillation with a very fast ventricular rate. How will this cause giddiness? So we need to investigate this patient further. So how do we in the outpatient investigate this patient? We usually place the patient on a halter, 24-hour. Nowadays we are having patch halters, 3 days, 7 days. We observe the patient for longer periods of time to see if we can pick up something. And nowadays the eye watches also. The eye watches are coming and people are very much, the Samsung watches also there, which pick up the ECGs, and the patient report to us with a particular ECG recording and say something like similar to this. My heart rate is very fast at times, and this is what is shown on the ECG. It is very useful at times. At times it misdiagnoses a lot of things, but then at times it is useful for the clinician to understand, oh yes, the patient did have an atrial tachycardia or an atrial fibrillation at that point of time. So this is a 3-day patch halter in the same patient with a history of giddiness. What you see here is when the patient is not in atrial fibrillation, the patient develops periods of sinus pauses. As you see there, there's a period of P waves, junctional rhythm, retrograde P wave, a pause, and then sinus, and then pause and junctional escape beats. So this particular halter tracing, the distance between this P wave to the other P wave, that's a duration of around 4 seconds. So this halter was reported as normal, but this is not a normal halter report. It was reported normal because there were no significant pauses, but the truth is this is not, you should rather classify it as a significant sinus pause, which was around 4 seconds duration with the junctional escape. That is the actual and the correct wording you'll have to use. Significant sinus pause of 4 seconds with junctional escape rhythm. This is the same patient presenting a few months later with this ECG. Complete sinus arrest, no P waves at all, and junctional bradycardia. And this time the patient presented with giddiness and fatigue. So what we are observing here is a patient at times with atrial fibrillation and at times with bradycardia. What is this atrial fibrillation at times bradycardia? This is what we call a 6 sinus syndrome, a tachybrady variant, again found in increasing incidence in diabetic patients. To maintain the patient on, they're quite young, 40s, so I would not prefer amiodarone in this patient, kept the patient on sotalol, and then a dual chamber pacemaker because the patient gets into episodes of obvious bradycardia. That is to protect against bradycardia, the pacemaker, and to protect against tachycardia, the patient is kept on sotalol, an antiarrhythmic medication. Now let's move on to the other end of the spectrum, which is tachyarrhythmias. 56-year-old obese female. She's an NRF in California, diabetic, hypertension, 10 years, chronic kidney disease, almost full-fledged diabetic and the complications of diabetes mellitus. Hemoglobin little on the lower side, EGFR is less in the moderately reduced EGFR category and high HbA1c. So the patient presented with paroxysms of palpitations. The patient was supposed to have a procedure in California, but the patient came here almost every day used to come to the ER telling with heart failure and palpitations. And you see the echocardiogram, quite a thick interventricular septum in this patient. The patient, this is in long-standing diabetes mellitus. When this happens, we classify these patients as a diabetic cardiomyopathy. These patients have sort of a restrictive physiology, a small left ventricle, and any arrhythmia of any sort in this in the atrium, these patients do not tolerate well. The patient also had comorbidities of hypothyroidism because the patient earlier was on amiodarone, and the patient has obvious obstructive sleep apnea. All these are highlighted because these are all predisposing factors for arrhythmias in a patient of diabetes mellitus. So see here, we see more and more patients in less than 60 years with atrial fibrillation. Why? The most important, single most important risk factor is diabetes mellitus. This patient, as I mentioned, restrictive cardiomyopathy physiology. Every time the patient gets into atrial fibrillation, the patient lands up in heart failure, what we call as HFpEF, heart failure with preserved ejection fraction. Paroxysms of atrial fibrillation recorded on the Holter. And this is an intracardiac electrophysiology study where you see a chaotic atrial activity. Those green signals are chaotic atrial activity within the atrium. That is atrial fibrillation. Most often these times, these atrial fibrillation come from pulmonary veins. So our job as an electrophysiologist is to disconnect the pulmonary veins electrically, what we call isolation of the pulmonary veins. So what pre-pulmonary vein isolation, you see some signals in the pulmonary veins, but post what we have achieved is complete cessation or silence within the pulmonary veins, and down the lane this benefits the patient because most often it is these pulmonary veins that trigger atrial fibrillation for these patients of paroxysms. Pre-procedure, the patient was on a lot of medications, but the current medications the patient is on, obviously the patient will be on lifelong anticoagulant for prevention of stroke, in addition an SGLT2 inhibitor and the other diabetic medications and thyroid medications. Now moving to the severe end of the spectrum of diabetic patients with chronic heart failure. These patients with chronic heart failure, deaths are cardiovascular, most often the deaths are cardiovascular deaths, and in the cardiovascular deaths, 70% of the times it is related to the pump or the pump failure, and 30% of the times it is because of the arrhythmias. Arrhythmias, when I mean arrhythmias, here I mean ventricular tachycardia or ventricular fibrillation. When a patient with arrhythmia related deaths, we usually offer an implantable cardioverter defibrillator as a secondary prevention strategy. Or if patients have a very severe LV dysfunction and we have, for example, an ischemic cardiomyopathy, we almost even for primary prevention, we say that this patient is at a very high risk of sudden cardiac arrest, give a defibrillator for this patient. And for pump failure, we offer a cardiac resynchronization therapy. So this is what a defibrillator looks like, an RV coil, long black coil put on the right ventricle that delivers the shock in between from the generator to the coil. That shock is delivered. This shock is delivered to reverse at ventricular tachycardia. What do you see? A VT is going on, a shock is delivered 36 joules from the device, and the patient returns back to sinus rhythm. But this is a painful event for the patient. Shock is quite painful. So most often we program the device such that most of the tachycardias are terminated without a shock, like that what you see, some pacing spikes coming and then the VT getting terminated. So what we call anti-tachycardia pacing. This is a 48-year-old female, non-ischemic cardiomyopathy. Most often diabetics do have coronary artery disease, but if they have heart failure because of no coronary artery disease etiology, we term it non-ischemic cardiomyopathy. The patient earlier had left bundle branch block, very common in diabetic patients. As we have mentioned, conduction disturbances are quite common, but these patients down the lane, some of these patients develop severe LV dysfunction. Yes, so this is a classical diabetic heart. What you see, speckled appearance in the interventricular septum, increased echogenicity in the interventricular septum, and a decrease in the left pump functions. So in these patients with complete left bundle branch block, we have to resynchronize the heart. Left bundle branch block basically is dysynchrony of the heart. So we have to resynchronize the heart by putting one lead in the right ventricle and one lead within the left ventricle. So this was what was done in the patient. Lead was taken into the left ventricle through the coronary sinus. We cannot put a lead directly into the left ventricle. Why? It will cause a stroke or a clot and a stroke. So we put a lead into the coronary sinus, get into the coronary sinus and place a lead there. That was what was done in this patient. We choose a very posterolateral tributary of the coronary sinus and there we place the lead. So at the end what happens? the QRS narrows. What we end up achieving in these patients are complete biventricular synchrony. So complete left bundle branch block is dyssynchrony. What our job is to resynchronize both the ventricles, make the both ventricles contract together, and hence result in a narrow QRS like that. So this patient before the CRT severe LV dysfunction and post CRT the LV functions better. What is more important is down the lane the improvement in ejection fraction, functional capacity, and these all translate to reduction in cardiovascular and all cause mortality in these patients. So the last of the case examples, 62-year-old